host city. We will continue to work with the Ministry of Health, Labour and Welfare as part of their task force to offer risk management advice right the way through the process. The final decision on the risk management measures for the Olympics and the final decision regarding the Olympics themselves is a decision for the IOC and for the Japanese authorities.
Dr. Aylward.
Thanks, Fidela. And just to further to Mike's point, this is not an issue about the Olympics. It's about an issue of how we use a scarce resource to try and combat what has been one of the most devastating, obviously, health crises of our time. And it has been disproportionately affecting certain parts of our populations. Our healthcare workers, as Mike said, have been, in some places, devastated by the numbers of them have been infected and severely ill or even died as a result. But most tragically is what we've seen among our older populations and our populations living in longer-term institutions. And I thought one of the more heartwarming things I saw, Mike, was it was an interview or a quote from an athlete who was an Olympic athlete who said there were a lot of people who needed to be vaccinated before I am. And really that's what it all comes down to, making sure that the people who need these products most. And this is, again, coming back to what the Director General said, in every country and every corner and every population of the world. There are older people everywhere. There are healthcare workers everywhere. We need to make sure they're protected everywhere. And right now, we have a real stretch on the available vaccines just to get into those populations and protect them.
Thank you. I would like now to invite Drew Hinshaw from the Wall Street Journal to ask the question. Drew, can you hear me? Drew?
Yeah, I can hear you just fine. Buddy, can you hear me now?
Yes. Yes, go ahead, please.
Hear me okay? Great, thanks. I just was hoping to have when we talk about, my question is kind of about Europe, specifically about Europe, if I can focus on the EU region, just to provide some specificity when we say wealthier markets are recovering in the second half of 2021, because even with all the resources that the EU has here, we're a month into vaccination. France, Germany have barely vaccinated more than 1% of their population. And some of that is supply constraints, but as you guys have noted, those constraints remain extremely tight for the foreseeable future. Then you have 40% of people who, in poll after poll, refuse to get vaccinated. So I guess when we talk about Europe or the global North recovering, how much do we mean that is transmission would be at zero? I mean, I guess my question is, how would you rate the likelihood that this disease will remain endemic to Europe even at the current rate of vaccination? Thanks.
Thank you. We have several questions here. Let's try to address them all.
Just address the issue of endemicity, the issues around vaccines and other things. I think there's always a risk that any disease will become endemic to human populations. In fact, that is the history of epidemic diseases in humans. We very often are affected in the first waves of a new infection with high-impact epidemics. They've gone back through history. Very often the disease, and this is a sad fact, that the disease, in historical terms, very often killed many, many people. And then as the disease moved into younger people, as older people became immune, the only new susceptibles were in younger kids as they were born. And that's why we've seen many diseases become diseases of childhood, because in effect the diseases have moved into those age groups and continued to kill over centuries. The issue for us in terms of looking at endemicity regarding a disease like COVID is that there are a number of factors that would allow us to believe that such a disease could be eradicated. However, there's a number of factors right now that we face, and there are headwinds. One is the absolute presence of the disease in so many countries, the fact that we're not seemingly able to implement comprehensive long-term measures to contain and control the disease. The availability of vaccines right now is not optimal, and in that sense, the current availability and for the foreseeable future, the coverage of vaccines will not reach a point where it will stop transmission, not necessarily. So we're likely to have continued transmission. The advantage we have right now, based on the targets that the vaccine has in terms of its efficacy, is we can significantly and very, very greatly reduce mortality, reduce severe illness, reduce the impact this has in our societies and on our loved ones and on those who are most vulnerable. And in that sense, we can return to normal life. Will this disease continue to transmit? Most likely for a long time. Unless we find the kind of compliance and the kind of vaccine coverage that will be required to achieve that. If vaccine coverage lags behind, particularly in younger adults, then yes, we will struggle to eradicate this disease. But remember, we've only ever eradicated one disease on this planet, smallpox. And we're struggling against polio, and we're struggling to eliminate measles. So the availability of a vaccine, the availability of the will to eradicate or eliminate, does not guarantee success. So I don't believe we should start setting elimination or eradication of this virus as the bar for success. That is not the bar for success. The bar for success is reducing the capacity of this virus to kill, to put people in hospital, to destroy our economic and social lives. We have to reach a point where we're in control of the virus. The virus is not in control of us, and that we have countermeasures in place that keep the capacity of this virus to cause harm to a minimum level, and we are back in control. I would look at that as success. If we look to eradication as the measure of success, I think we're going to struggle. Bruce?
Thanks, Mike. Listening to the question, sorry, I was just trying to untangle it like Mike was a little bit. But really the question, the way I heard it was, how much do we expect vaccines may change the shape of this epidemic or this pandemic? In some ways, we don't know. But what we do know in 2021 is that we should be able to substantially change the human cost of this crisis through the use of vaccines. We know that this virus disproportionately affects certain populations. The older people, as we've talked about, people with comorbidities, people who are highly exposed, like healthcare workers. So the real goal of vaccination this year is to take the heat out of this epidemic or this pandemic, is to, like Mike said, to reduce the human toll in terms of deaths and severe disease. And that comes back to the theme you're hearing again and again and again. We can only do that if there are sufficient, let's say, equitable allocation of these products in a way that those populations at highest risk get reached everywhere. And I thought what was staggering today were the numbers that were released by the study that you heard presented, and then the comments from the head of the ICC as to the economic case for doing what we know is the right thing from a moral or a health or a health equity perspective. So the real goal, this year, could we take the heat out of this pandemic with these products? That was always the goal, and very definitely we think by the end of this year we could do that. But it is going to take making some tough choices about how we equitably allocate and use what is right now a scarce product, and will be for some months to come.
Thank you, Bruce. This is a good bridge. Inviting now our experts to answer the economic angle of this Wall Street Journal question. Professor Sebham, do you want to answer? And Dr. John and Mr. John Denton, you will have the floor too. Over to you.
Sure. I would like to actually highlight the global interconnection point again that Dr. Denton made forcefully, because here, if we look at two scenarios we did in the study, one is this extreme scenario that gives you the 9 trillion number where no vaccination whatsoever in the rest of the world, but advanced economies recover immediately, like, right away, like beginning of 2021, right? So the total cost is higher there, world cost, because the rest of the world is bigger. And then almost, close to half is borne by advanced economies. Now, we go to a more realistic scenario we worked out. Advanced economies still have the disease in 2021, going back to the question from Wall Street Journal, but we still assume that they are done with vaccination mid-2021. And by the end of 2021, early 2022, half of emerging market and developing economies population vaccinated. So, I mean, this might be, there's more realism to this. We might not be there by end of 2021, but in this scenario, there's still disease going on in advanced economies half of the year. Very interestingly, the global costs go down, right? I mean, you go down actually from 9 to 4, but also very interestingly, the share advanced economies bear go up. Why is that? Because in this scenario now we allow some vaccination also in emerging market and developing economies. That helps to the exports and imports of advanced economies. And advanced economies are larger, so the world costs go down. But they are going to bear a higher share because now they also have to deal with the disease in their own economy. So these global interconnections, both on the export side and also imported intermediate input side, can be really, really important in amplifying economic costs. So it is extremely important to highlight again that there is an economic case to be made here on top of the moral case. Thank you.
Thank you, Professor. Mr. Denton, you have the floor.
Thanks very much. Just picking up on a couple of things, I'll make 3 quick points. First of all, one thing Mike said, which has really struck me, I mean, what we're seeing is, with the history of epidemics and the way they flow, with all the things that are happening, the developed world and rich economies have a greater chance of actually managing the trajectory. And as you say, eradication is not mark of success here, but for where we are. But what we're really worried about, without the equitable distribution, it's developing countries, and the history is they will not be able to manage that trajectory. And so you will actually end up potentially with a managed trajectory in the north, but actually an unmanaged trajectory in the south. And this is a real concern. It will simply exacerbate, particularly with the new variants coming in and the speed with which they're moving. And so that's why we really want to emphasize the output of our study, which has been so eloquently described by the previous speaker, is that there's an economic case, and it's a compelling economic case, not just persuasive, to actually fully fund the COVAX facility. And the reality here is I've called out on a number of countries, but Japan, Australia, Canada, and China and the US need to continue to step up, and all the constituent parts of the European Union. 2 other quick points. First, the issue the WSJ made about distribution. One element that we see, and we'll be mounting a global campaign on the involvement of the private sector to actually step up here, and we'll be launching that during the course of the next week, which will cover multi-dimensions, including the output of this study. The first is, if you're going to have a successful national vaccine action plan, you must involve the private sector. The wisdom and the knowledge and the innovation of the private sector in distribution can never be underestimated. And it's the genius of the innovation of the private sector which will help on this distribution, not just in developed countries, but also in developing countries. And it's really important for those national vaccine action plans to involve deep engagement with the private sector. That was missing in the pandemic action plans of so many countries, engagement with the private sector, and it took us a while to actually help get countries to realise the importance of that. And I shout out to Dr. Tedros for realising the importance of engaging with the International Chamber of Commerce as a conduit to actually reach out to the private sector. The third point, and if you actually look at the most recent trust index of Edelman on vaccines and ensuring this 30 to 40% of people in Europe who are so suspect about the taking a vaccine actually get confidence. The people that individuals trust, the entities they trust, it's not government, it's not international organizations, it's business. Business, people have trust and confidence, and we want to use that trust and confidence to help individuals and citizens understand the importance of accessing and actually utilizing vaccinations as well. And that will be part of the ICC's global campaign involving the private sector on a continual basis in the actual debate and the implementation of an effective, fair and equitable distribution of vaccinations and vaccines across the globe.
Okay, thank you both. I would like now to call on Gabriela Sotomayor from Proceso to ask the next question. Gabriela, can you hear me?
Hola, thank you very much. Happy birthday, Fadela. I have a question on Mexico. Mexico is betting everything on the vaccine like many countries, but it is one of the countries that does the least number of tests. And now, for example, in Mexico City, hospitals are at the maximum capacity. We have record numbers of cases and deaths. Until January 12, for example, an average of people died every hour. So my question is, do you think it's possible that one of the new variants is circulating and has not been detected due to the very low number of tests they do? And on vaccines, medical personnel are in danger of missing the second dose due to Pfizer problem with temporary suspension of shipments. Also, the government decided to vaccinate 20,000 teachers in Campeche, a state of Mexico, instead of health personnel. So my question is, what is your assessment? And that's it. Thank you.
Thank you, Gabriela. Dr. Von Kerkhoff will take this question, and then maybe Dr. Ryan.
Thank you, and our best wishes to the President of Mexico. I know that Dr. Tedros sent a message earlier today, but from all our staff here, we wish you speedy recovery. The situation in Mexico is, we've hit 1.75 million cases and approaching 150,000 deaths. And, 19% of those cases required hospitalization. And you're right, the positivity rates are high, which probably does, and I've said this again and again, does represent under-testing over many, many months, and probably not the extensive testing that would have picked up even more cases. Again, there's over 200,000 cases amongst healthcare workers, 47% of whom are doctors and 40% are nurses, and the rest other support workers. So again, this has had a big impact on healthcare workers around the country. We've seen similarly to indigenous populations relatively low numbers, under 15,000 cases, but that includes 2,000 deaths. That's 1 in 7 people from indigenous communities who are sick, dying. So we've seen very sort of important impacts on those groups. In general, bed availability in Mexico is quite good. There's 60% availability of COVID beds and about 40 to 50% availability of ICU beds. So the health system in general is coping in Mexico. With regard to vaccination policies, I think Bruce may speak to this. All countries are struggling with the issue of getting vaccine and then deciding the scheduling and whether they go for giving one dose to everybody and then trying to delay the second dose a little. All countries are trying to, do this pretty demanding arithmetic for what is the best combination. So maybe Bruce can speak to how our other colleagues online on how we're advising there. I would say in general that we're seeing a pattern in Central America that's stabilizing. We're still seeing a pattern in South America, not just in Brazil, in Amazonas and other Amazonian provinces. We've seen big impacts, but we're also seeing rising cases in Colombia, in Peru, and while we're seeing stabilization and falling off of cases in places like Chile and Argentina and the Southern Cone, there are parts of those countries that have intense outbreaks. So I would say the overall pattern in the Americas is beginning to stabilize. The increases are not as stark as they've been, but the health systems across the whole region are under pressure, and people, like in the rest of the world, are very, very tired. So I'm sure vaccination couldn't come quick enough for people in the Americas. And again, remember, the Americas has been one of the most deeply and persistently affected regions in this whole pandemic. Other regions have had a relative break. There was been summer in Europe and there was a relatively small number of cases. We've seen, for example, in Southeast Asia, Western Pacific, even in Africa, smaller numbers. But the Americas, and particularly Central and South America, has had a punishing pandemic in terms of the persistence and the relentless impact of the disease. And as such, systems are under pressure, and people need help. And we hope the vaccine, as I said in answer to the previous question, vaccination can't come soon enough, both to take pressure off those health systems and to protect those highly vulnerable people. And countries are facing difficult choices. I can't comment on the specifics of where Mexico has prioritized its specific batches of vaccine. I'm sorry, I don't have that level of detail, but we can certainly check that out with our PAHO team, and I will do so. Bruce?
Thanks, Mike. And Gabrielle, I thought one of the most important points you highlighted was right at the beginning of the comment when you talked about betting everything on the vaccine, because, of course, if any country bets everything on the vaccine, we're going to lose. That's the bottom line, certainly in 2021. The vaccine is one tool, but we need a full armamentarium if we're going to beat this virus. We need to make sure we've got our first, second, third lines of defense all working. And your vaccine is going to be your first line of defense to help prevent people getting infected. But people are still going to get infected. We know we're at a scarce situation in terms of vaccine supply. You've got a virus that's changing all the time. You've got suboptimal uptake and hesitancy with the vaccine. There are many, many issues that'll affect coverage and the ultimate protection from the vaccines. So that makes essential the second line of defense. You've got to be able to test, find that infection so that you can isolate people who are infected, quarantine those who are in close contact, and then you have to have your third line of defense. You've got to have the ability to treat and give high-quality care with oxygen, dexamethasone, other life-saving therapies that we know can really, really reduce the rate of death to this disease. So now, I mean, the good news in 2021 is we've got vaccines, we've got new rapid diagnostic tests that we know work. We know the combination of corticosteroids and oxygen and other interventions can substantially reduce the probability of dying. So we have an extraordinary armamentarium when you compare us to where we were, certainly when Maria and I were in China last year. But the reality is you need all three of those lines of defense if this is going to be successful. And again, when it comes to the use of the vaccines, these vaccines have gone through clinical trials and they've been tested a certain way. They've been tested as 2-dose schedules for the vaccines that you mentioned. They've been tested with certain intervals, and that's how we know they work. That's how they need to be used. So we strongly recommend, and I think this has been a strong international consensus from the advisory boards, the big international advisory boards like SAGE that advise WHO, that we need to respect the interval that has been recommended for the use of these products. Now, that said, there are reasons there's going to be delays. Someone might get their first dose, and there can be many, many reasons that they are not getting the second dose exactly at the right time. And this can be because of many reasons that are out of people's control as well. They're also out of the control of suppliers. We're dealing with a biologic process with new products here. So it is a real challenge to meet what are very, very demanding production schedules. But the important thing then is make sure you do get the second dose, to the point that you were saying, Gabrielle, even if it is delayed. That is the message. But the recommendation is use these vaccines the way they've been approved, the way they've been trialed, because that's what we have data for, and that's how we know they work best at this point. That knowledge is evolving all the time. We'll get more knowledge. And we also respect that certain countries will do things slightly differently, Mike, as you said, to try and address the circumstances in their particular environments.
Dr. Van Kerkhove.
Thanks. Just to add a couple small points, because you mentioned the variants, and I know that there are a lot of people that are concerned about the virus and changes in the virus and what this means, and does this totally change the game? And I just want to reiterate that everything that we are learning about these variants and doesn't change our approach to controlling COVID. You know, there are 4 elements that countries are working towards, and you hear us talk about these all the times: prevention, control, treatment, vaccination. All of these elements that you've heard us talking about, and now we have vaccines and vaccinations. It will take longer than all of us want for vaccinations to have the impact that they will have, but we have other tools. We have to right now prevent as many cases as we possibly can, for all of the reasons that you know very well. Not only to make sure that we keep ourselves safe, but we keep our loved ones safe, those who have more underlying conditions, who are at a higher risk of developing severe disease and dying. We have options for control. It's all of those elements of active case finding, rapid, reliable tests, making sure that individuals know if they are infected or not, making sure that they are put in a clinical care pathway and receive quick assessment, oxygen, dexamethasone if they are severe or critical, and more therapeutics that are coming online. We need to make sure that we prevent infections through vaccination. We make sure we do individual level measures by hand hygiene, physical distancing. all of that still holds true. Don't forget that we still have some power over this virus, no matter where we live. And as these vaccines come online, you still have some control over what you do during your day, over the exposures that you may or may not have. And you have information, you have knowledge, you have tools that you can take to prevent yourself and your loved ones from getting infected. So I don't want you to forget that. Even with these variants and what we understand with these variants, these control measures work. We are seeing reduced incidence in a number of countries that have different virus variants that have been identified in South Africa, in the United Kingdom, in Ireland, in Denmark. The control measures work. So don't forget that we still have this control, and countries are doing what they can. I am struck by the conversations we are having 1 year into this, and thinking, I want people to remember that there's still a lot that we've learned, and that there's a lot that we can do. So prevention, control, treatment, vaccination. Thanks.
Just to add specifically for that, we don't have specific information on sequences in Mexico per se. I'm sure that Mexico has uploaded some sequences to some of the platforms, but we haven't any indication as yet of any unusual or variant strains on the Mexico side of things. It is, though, important, and you mentioned the point that the more testing you do, the better, and that's good for control, that's good for understanding the epidemiology. But a proportion of those samples should be sequenced, so it should be done as systematically as possible. But not every single test needs to be sequenced, not every single virus. And you need targeted sequencing when you see unusual clusters or unusual patterns of transmission or unusual clinical presentations. So what we're trying to do with variant surveillance is to ensure that we're just watching out over all of the disease that's happening in the world with usual signal, and ensuring that we're specifically targeting not only testing but sequencing in those areas. And Maria and the group here are working on a systematic framework for doing that with countries, and we hope that all countries who wish to enhance their genetic sequencing capacity and contribute that data to the global knowledge will be able to do so. If they wish to make that commitment and wish to buy into that, we are certainly in a position to help connect them with the necessary technology and training to achieve that.
Thank you. Maybe we can take a last question from South Africa. Sophie from SABC. Sophie, can you hear me? Sophie? Can you please unmute yourself? Sophie from SABC. Sophie? If not, maybe we can close with last question from Kai, from Science. Kai?
Yes, thank you very much for taking the question. It follows neatly from the last one. I wanted to ask, Moderna announced today some good results in terms of efficacy of their vaccine against the South African variant and the UK variant. But they also said that they were working on updating, on developing a booster shot, essentially both based on the normal virus and based on the variant that was first described in South Africa. I would just like to get an opinion from WHO on, what would you like to see from other manufacturers in terms of doing this? And is the regulatory approval, do you feel like it is clear what the regulatory approval will be if indeed it becomes necessary to update a vaccine?
Thank you, Kai. Dr. Aylward?
Yeah, hi, Kai. That's a great question. And in fact, one of the things that we're doing right this week in the area of the ACT Accelerator is we're revising the whole strategic plan, or refreshing it, let's say, in light of what's going to be necessary in 2021. And some of the big drivers of that, of course, are the increasing detection of the mutations, the variants that we're seeing, the variants of concern, let's say, with the particularly the changes in the spike protein. protein. The other big driver, of course, that we're working against is just that demand for vaccines. So these are the big things affecting the work. And while our first priority going forward is going to be the rollout of the vaccines that we have, because as you've reinforced and as Maria said earlier, we know that these are working against the variants at this point. So the important thing is to get those things out, as much coverage as possible, protect as many people as possible. But the second priority that we're building into that is how we bolster the whole R&D agenda. And it's really the agenda across the research and development, across the product assessment work that we do, and then, of course, the regulatory pathways work, exactly to the point that you mentioned, Kai, because what we have to define is what is the regulatory pathway, if necessary, for strain changes. So that's exactly the program of work that's kicking off right now. And in terms of from the manufacturer side, what we're going to be looking for is the same kind of collaboration, early stages of this disease that we saw last year, where there was a great sharing of information, and alignment around what are the assays we're going to be using, what are the correlates of protection, what are going to be the key strains that we'll be using. So all of that you want to get as standardized as possible, and then the trial design standardized, et cetera, so that you can compare across products as well. So I think we're going to be going into a period where we'll want to be seeing even more collaboration across producers to try and then together look at how do we both assess the changing environment we're in with the variants, but then also how we respond to it in terms of the R&D, product assessment work, regulatory work when it comes to strain changes. So very much at an early stage in that, but fantastic that Moderna and others are already looking at what does it actually mean for their products as they go forward. Because, as we've seen over the last year, and science has done an extraordinary job in this crisis. And again, to the point that Maria made a little bit earlier, variants of concern are there indeed, but I think we've got the science now, if we harness it properly, to stay in front of it as the nature of this pandemic and the virus unfold.
Thanks. I just want to take it a step up from that as well, because it does link to this monitoring framework that we are establishing, and then linking to exactly what Bruce just described. What we're trying to do is working with partners around the world to make sure that we have an enhanced system to detect a change in the virus when it emerges. But we also want to be more proactive. So if we're looking at different types of mutations that we are seeing, we want to look at combinations, and we are seeing some of these in different variants identified in different countries. Those need to be evaluated properly. So we're doing this through enhanced epidemiologic surveillance around the world, making sure that we have robust systems to track this virus and who is infected with this virus. So first and foremost, we can reduce transmission, but also so that we can look for any changes, any significant changes in transmission where we wouldn't expect it. For example, in an area where interventions are in place and we're still seeing transmission. That was how the United Kingdom identified their virus variant in December, November and December. But also if there's a change in severity. We want to increase sequencing surveillance around the world, and we have incredible sequencing surveillance increased over the last year, but that needs to be stronger. So we're looking to leverage existing systems, and we already are doing so we're not starting from scratch. We have the GISRIS Flu Network, global network, in which 89 labs are currently doing full genome sequencing for SARS-CoV-2 already, and we want to increase that. We're very thankful for our flu partners. We have the SARS-CoV-2 network, many of which are overlapping with the flu network, of course. We want to harness the expertise of the polio networks, our HIV networks, our TB networks, because there are systems in countries that can do sequencing. And the more sequencing we have, the more sequences that can be shared. So in addition to doing that, we are working with our partners to share those sequences on platforms like GISAID, and others with metadata so that we can analyze them and carry out bioinformatics and phylogenetics. We have our virus evolution working group that is tracking each of these mutations and understanding and designing and collaborating on which lab studies need to be done. And this is just looking at mutations, looking at variants of interest, and then variants of concern. And then, of course, we need to link with the manufacturers, with the animal model working groups, and Bruce outlined what those studies need to look like. This is a process. This is something that needs to be done in a robust, in a transparent, in a coordinated manner. And we need to make sure that partners are being utilized to be able to carry this out. Again, we are leveraging existing systems. We're not starting from scratch. We have the R&D blueprint for epidemics. We held a meeting a few weeks ago to outline all of the studies that need to be done, again, in a coordinated manner. We had a meeting a few days later, again, organized by the R&D blueprint, looking at vaccines. So this is something that will continue. This is something that will be enhanced over time. Viruses do change. But I go back to what I said previously, we still need to focus everything we can on preventing as many infections as we can while monitoring virus circulation globally.
Thank you all. I would like now to hand over to Dr. Tedros for final comments. Over to you, Dr. Tedros.
Thank you, Fadila. And my appreciation again to John and Professor Shebnem for joining us. And thank you also to all colleagues from the media who joined. And see you in our next presser.
Thank you, Dr. Tedros. You will receive the DG remarks and the audio file of this press conference just after this press conference. The full transcript will be posted tomorrow morning. And for journalists who were not able to ask questions, please don't hesitate to contact the media team of WHO for any pressing questions you have. Have a nice evening and see you next time. Bye.